Good afternoon and welcome to a UMB Town Hall. Ask the experts about COVID-19 vaccines. I'm Alex Lukowski, Executive Director of Media Relations. The Delta variant, booster shots, vaccine requirements, there is a lot to talk about. So let's start with the basic facts. As it stands now, 56% of all Americans have received at least one COVID vaccine dose, and 48% are fully vaccinated. That still puts our vaccination rate behind countries like Uruguay, Bahrain, and Mongolia, along with much of Europe. The reason why is often referred to as vaccine hesitancy, but that is a misnomer. In Black and brown communities, it's often a complicated blend of impediments to access and mistrust founded on well-known historical incidents. And poor Americans of any color often worry that an adverse reaction to a vaccine could render them unable to work or care for loved ones. Another culprit is vaccine mythology. We've all heard these. Vaccines cause autism, they can alter one's DNA, young people really aren't at risk. And anyway, we don't need them because the infection rate is already so low. But one of the most powerful obstacles to progress is still politics. The Kaiser Family Foundation found that 54% of Republicans say they have or will be vaccinated, but almost a third said definitely not or only if required. Among Democrats, it was 88% who said yes and about 5% said no way. And similar divides also exist between urban and rural Americans and younger and older Americans. Religion also plays a big role. According to a Pew Research Center study last year, the largest group of holdouts are evangelical Christians. Nearly half of the country's 41 million white evangelicals said no to the vaccine, many citing the use of aborted fetus cell lines in the development and or testing of vaccines. And now following some months of subsidence, COVID is on the rise again. Here in the US, the 7-day average of new cases has about doubled in recent weeks, and hospitalizations are going up as well. It's surging, especially in the South and Mountain West areas with some of the lowest vaccination rates. Major cause of concern, of course, the so-called Delta variant. Viruses left to replicate tend to mutate, and sometimes into more infectious or more virulent variants. Now, this one, first identified in India, is estimated to be probably 2.25 times as infectious as the original strain detected in Wuhan, China, and has very recently become the most prevalent strain of COVID in the US. Now, there's evidence that it may lead to more severe disease. A study in Scotland published in The Lancet found the hospitalization rate of patients with the Delta variant was about 85% higher than those infected with the original UK variant. Another study showed the variant grows more rapidly inside the respiratory tract and to much higher levels. There is good news regarding the Delta variant, however. The country's leading infectious disease expert, Dr. Anthony Fauci, says all three vaccines available in the US are very effective at preventing infection from the original strain and the Delta variant as well. Now, that explains why every one of the Marylanders who died of COVID in June was unvaccinated. While the Delta variant may provide good incentive to get the vaccine, recent news reports have raised some more cause for concern. The FDA has added a warning label to the Johnson & Johnson vaccines label after finding a small number of cases of Guillain-Barre Syndrome among millions of Americans who've received the vaccine. GBS is a rare neurological disorder in which the immune system attacks nerve cells. The impact can range from brief and mild weakness to severe paralysis. I should note that there were just about 100 cases, probably, discovered among 12.8 million vaccine recipients, meaning a vaccine recipient is about twice as likely to die at the pool this summer than contract GBS. So with our great divide over vaccination, it seems fitting that the two biggest questions Americans seem to be asking right now are, do I need a booster shot to stay safe on the one hand? And do I need to be vaccinated to go to work? And why do I need to be vaccinated? For school or for travel or other things? Regarding boosters, Dr. Fauci made the rounds of the Sunday morning talk shows recently, reaffirming the CDC FDA joint statement, which said, quote, Americans who have been fully vaccinated do not need a booster shot at this time. That statement went on to say that they are rigorously looking into when and if that might be needed. And as for vaccine requirements, the nation is all over the map on this one. More than 500 universities like UMB have vaccine requirements, but most do not. Grade schools in 13 states, many with the highest number of COVID cases, won't require a vaccine this fall, and others will let local school boards decide. Employers, of course, are still working things out. The EEOC says federal law does allow employers to require vaccines to return to work, subject to reasonable accommodations, whatever those are. But to many Americans, there's nothing reasonable about being required to get a vaccine in the first place. Some even call it an assault on American liberty. But consider the words of one American general who argued in favor of the forced vaccination of every soldier under his command to protect them against disease. Quote, we should have more to dread from it, the disease, he wrote, than from the sword of the enemy. Necessity not only authorizes, but seems to require the measure. You may have guessed that those were the words of George Washington in 1777. He was writing about the smallpox vaccine because it was disease, not musket balls, that caused the most deaths during the Revolutionary War. And most historians credit those forced vaccinations with the ultimate success in the field that led to the freedom of many people in places like Baltimore. And it wasn't even approved by the FDA. We have two fantastic panelists here to answer all your questions today. Sarah Edwards is Assistant Professor of Psychiatry in the School of Medicine and a co-investigator for UMB's Health Resources and Services Administration grant focused on public perceptions and attitudes about vaccines. And Matthew Lawrence, also from our School of Medicine, is a pediatric infectious disease specialist who conducts research with the Center for Vaccine Development and Global Health. Welcome to you both. I want to quickly note that this is our first hybrid event, so we're working out a few bugs. Bear with us. Some of our audience is here in person in the HSF2 auditorium. The rest of the audience is joining us via WebEx, as usual, at least in these last months. The audience at home can see everything going on in the room here, and members from both audiences will be able to participate. It's time for questions. Folks here in the auditorium can raise a hand. We'll ask you to speak up so everyone joining virtually can hear you. The WebEx audience can use the chat button. Use the chat button to write your questions, send them to me. I'll call on you by name, unless, of course, you want to remain anonymous. And of course, the program is being recorded and we posted on the UMB homepage, umaryland.edu, and it's being live streamed on Facebook Live. Now, with all that out of the way, I'm sorry it's been so long. There's a lot to talk about. Please welcome our host, UMB President, Dr. Bruce Gerald.
So part of what I hear is that people hear a lot of different things on the internet or on their songs or on their conversations. Or, so for the two of you, what are your trusted sources for data? And were you not a physician, but rather a lay person? What should we tell them their trusted source should be here?
Well, I'm always going to say to reach out to from a child perspective, reach out to your pediatrician. Reach out to that doctor that you trust, to the nurse that you trust, to, make sure that that's a person who knows you really well. Pediatricians have seen your kids throughout the years. There's so many welfare visits early on, and they know you and your family. And so that's an important, very important place to go to get additional information. If you're looking on the news, there's so many different sources, and I think we're in this generation of just, it's overwhelming. The amount of constant media coverage, and the phone is dinging with, new news alerts here and there, and it's so hard to sometimes block it out. And so I think it's really important to decide, to ask your physician and get the information there, and then to be smart, be a good consumer of different places. I know I've recently read that one of the things we can do is sometimes to challenge ourselves. So we tend to listen to only one news station. Actually listen to maybe the other type political connected news station, because you should be hearing similar, the correct information should be there as well. And so that's one of the strategies that helps us kind of fact check and get that additional information.
I'll have to try that.
Yeah.
That's going to be
it's hard, but it's good for your mental muscles there.
Yes.
And also for kids, self-regulation, right? So that you might get a little bit more upset, and you'll learn some of those skills as well.
Dr. Lawrence, would you add anything?
Sure, I agree completely. So I find that I'm looking mostly at the CDC and encouraging others to look to the CDC, where they have pages that are dedicated to the lay public as well as to healthcare professionals. And that is a trusted source of information. Also, the Maryland Department of Health and Human Services maintains a website with very useful and important information for COVID-19. So those are the two sources that I would recommend. As far as data goes, we do see data coming out from many different sources, and sometimes the most recent data can be, say, at the New York Times. The NewYorkTimes.com is another place where we frequently look for information. But again, for most questions, I would refer you to the CDC website.
Right, when people ask me that question, I say when Dr. Fauci speaks, and I listen. Because for those of you in the listener community, he's been an expert in this arena. How long has he been at NIAID? It's got to be well past 20 years.
Yeah, decades.
And So I think he's earned his stripes. And I find him very informative, and he doesn't overcommit. And I think the important part for the audience is what we know today is what we know today, and what we know tomorrow may be different. But certainly, as this has rolled out, these have been very safe vaccines. Now, you mentioned something earlier to me, Dr. Edwards, about fear of needles. Now, I'm a surgeon. I can understand the fear of knives. I have trouble understanding fear of needles. Could you tell us a little bit about that?
Sure, absolutely. It does sound surprising to some people, but about 10% of the population has a severe needle phobia. And so that impacts decisions, and many people do not get routine vaccinations, the flu vaccine, because it's such, they've had traumatic experiences and it's very scary. I think COVID has made it a little bit harder too, because knowing that initially there are these massive vaccine sites, so the fact of knowing that you're already nervous and then there's going to be lots of people around you made that fear increase a little bit more. So in the hospital system, we have some groups where I'm available to help people individually. I tell the story of I was waiting to pick up my daughter, so I was in a coffee shop, and I started talking with somebody who worked there, and she was a young woman in her 20s, and she mentioned something about the vaccine, and she said, I haven't gotten it yet. I said, tell me a little bit about that. She said, I'm so afraid. Of course, this is like, yeah, of course. And she said, I'm so afraid of needles. And so we continued. I said, that's really interesting. I'm working in the hospital on something like that. And I actually helped. We signed up right then and there. I said, would it help you if somebody was right next to you and could work on some breathing techniques and kind of be there to hold your hand? So she came down here. I met her over at the student center, and she got both of her shots. We did it a couple weeks apart. So that was a fun way of kind of bonding together in this community, in this challenging time, but realizing that there's many reasons why individuals don't want to get vaccinated. And so sometimes it is something like needle phobia, which I know for a surgeon is hard to find, but.
Well, I got one of my scheduled vaccinations on, what's the date, Thursday, on Tuesday. And I have to admit, I didn't even feel it. Okay, I was distracted by the manipulation, and it was a very effective strategy. So I didn't even feel it. Alex, I just want to check, remember in our audience, we have the ability to ask questions. That applies to anybody in here. I have a question in the back of the room. How should we do this, Alex, since we're new at this?
Go to the blue room, that's fine.
We
We do have a question online if you'd like.
Okay, does he just yell?
Just
Speak up, yell.
Repeat his question.
I'll repeat the question. I'll repeat the question. Good afternoon.
Thank you for this session, and I'm start here. And just have a question that it's a developing representation in the developing countries. So if they have access to one kind of vaccine, usually they have access to the first dose, but due to some reasons they could not get the second dose of the same. Let's say company. Is it okay? Say get the other company's vaccine with the other.
So you want to repeat the question and then answer?
Sure, I think I understood your question. You can correct me if I didn't, but you're asking about the situation that often happens in countries where a vaccine supply is limited and individuals get the first dose of a 2-dose vaccine regimen, but the second dose isn't available for whatever reason. Would they be able to get a second dose from a different vaccine manufacturer and still be considered protected?
Yeah.
So I guess I could take that, and you could chime in if you like. But so what you're asking is are we able to state that an individual would be protected if they got 2 doses of vaccines from different manufacturers? And the answer is we simply don't know that yet, but that is continuing to be studied, and we would call it in the vaccine research field a mix and match studies. So where we would start with one vaccine and then end with a different vaccine against the same disease, but hope that we would have similar protection as if you had taken both doses of the same vaccine. So there is reason to think that that would be an effective strategy, and certainly we would want to know more about the efficacy of that strategy as well as the safety of that strategy, because different vaccines have different side effects, and we would want to be able to track that. But good question.
Follow up on the same question. So if you have the first vaccine and you ignore the first dose of one kind of vaccine and you get second doses of other companies,
Sure. So if you start out with one dose of one vaccine manufacturer, and because you can't get the second dose from that 2-dose regimen, you go to a different manufacturer, and then you get 2 doses of that different manufacturer's vaccine. So a total of 3 doses for a COVID-19 vaccine. And what we would really want is safety data for sure, and then also efficacy data. If you get the recommended dosing from any manufacturer, we would expect that to be protective. So if you get the 2 doses from the second manufacturer, we would expect it, again, to be protective. But the safety profile after 3 doses just has not yet been studied. So that's what we would want to know.
also they also do like the vaccines are from DNA-based, protein-based, and so will that have some kind of effect of getting different vaccines? Get the second 2 doses of the company.
Absolutely. So the question and follow-up, the second follow-up question was, if you get an initial vaccine dose that's based on a certain technology, say DNA technology, and then the next doses, the next 2 doses would be from a separate technology, mRNA or a viral vector-based vaccine, for instance, what effect might that have on vaccine efficacy as well as vaccine safety? And again, the answer is we don't know, but there are potential effects. On vaccine efficacy, many of these vaccines use the very same antigen or piece of the virus that stimulates the immune system. So if you have that same piece of the virus that stimulates the immune system 3 times, you can imagine that you would continue to see an increase in the immune response. But as far as the way that that piece of the virus is presented to the immune system, it differs with regard to DNA vaccines and RNA vaccines and viral vector vaccines. So we would want to know more about the safety profile before that could be recommended as an acceptable alternative. Yeah.
Thank you for that. I have one other question here.
I have sort of it's kind of like a human behavior question, so it's probably best for Dr. Edwards. I'm thinking sort of back to the polio epidemic, and there was fear, and people were seeing iron lungs, and there was a lot of work to get a vaccine, and I know there were some issues. We're in a similar situation. I mean, last year we saw like morgues set up in Central Park and stuff, so there is this fear. But then there's also this, like government mandates, employee mandates, differing information. How do you address that anxiety so that we get individuals to really kind of look at the facts? In this country, we're lucky we have access to professionals that have made themselves available with this very good messaging. But how do you get beyond that anxiety of mistrust and issues like that may curtail people from really considering all the information?
Great question. And such an important and challenging one. And I wish we had kind of that quick answer and quick, medication or solution to it. And it's not. And so it's really about surrounding yourself and getting it, the appropriate and safe information. So Dr. Lorenz has mentioned about the CDC. I always encourage families to be talking with their healthcare professionals, individuals in the field that they trust, and to take all of that in. And then, if you need to be talking with professionals to kind of help sift through some of the facts, that's important to do. And it's really important to be together. We are human beings who need to rely on that interaction and relationships. So you're not alone, right? So when you're questioning and having those same sort of worries and concerns, it's helpful to talk about that in your family, with your close friends, colleagues, in your church, your community, and kind of get a sense of what other people are doing too. And so I think that's one of the ways we know that when we can talk about something, then we can deal with it. Mr. Rogers always said, if you can talk about it, if something is mentionable, then it's manageable, right? And so that's really, from that perspective of making sure that we always are able to say it out loud and talk about it. And so that, I think, is the biggest way to get us through this next phase of the pandemic.
And it's so good to be back.
It is.
Alex, before I get,
We do have questions from the WebEx.
I got another one in the audience here.
Okay, well.
Let's go back and forth.
Yeah, sure. So I have a question from Peter Doshi, who's in our School of Pharmacy. He writes, I'd like to ask a question about vaccine safety. He came to the right place. There's a view out there that serious side effects always occur within 6 to 8 weeks of dosing, and that now that the vaccines have been out for half a year, we have a really good sense about the adverse event profile. But is that really true? Take myocarditis and pericarditis, for example. It wasn't until recently, around 4 to 5 months into the vaccination campaign, that myocarditis was recognized as a harm, particularly in young men, which Israel estimated occurred in 1 in 3,000 to 1 in 6,000 vaccinated men 16 to 24 years old.
Dr. Lawrence, you want to start with that one?
Sure. Thanks for the question. So the question is regarding our ability to detect any adverse events that are associated with vaccination. And in the case of myocarditis, this is something that was detected 4 to 5 months into the vaccination campaign. So why did it take a while? Well, the reason is that basically it's a very rare event. And our very robust safety monitoring system was able to detect this very rare event and examine it very closely. And that's how we honed in on the fact that, yes, it happens more frequently in males. Yes, it happens more frequently in younger individuals, so that we could further characterize that risk and let the public know exactly what we know, and that is who is most affected and what is the rate at which they're affected. So there are risks that are rare that will take longer to detect, and that is ongoing, as I said.
If I could just interrupt for a moment. So Dr. Doshi, he left a lot of lines blank, and then later on down, I didn't see it right away, was a real question. If I could just finish that question. He said, so my question is, why did it take 6 months to discover myocarditis, which appears days after dose 2? And what are the implications of this fact in terms of finding either serious adverse events down the line that we aren't talking about today, say months or years from now?
Sure. So as I said, this very robust monitoring system that we have to detect these very rare side effects did pick up on the myocarditis risk. And the question is, are we going to detect other potential side effects of vaccination? It's possible. It's very possible. But we can have confidence that the FDA and the CDC will let the public know what these risks are and who is at highest risk. There was a recent report of Guillain-Barre Syndrome that occurred after the Johnson & Johnson vaccine. This was made known to the public. This occurred only, so far, we've detected it in about 100 individuals out of over 12 million doses that have occurred. So this is something that is ongoing, and it's something that your government will continue to notify you about.
And let me add, in terms of the myocarditis issue, the University of Maryland, both here at Baltimore and at College Park, conducted a study of athletes among the Big Ten schools. And in that study, the incidence of myocarditis or findings on cardiac MR of that group of several thousand student athletes was about 2%. Now, let me make clear, these are young men and women who had COVID, not the vaccination, but who had COVID and who had myocarditis. And of that 2%, 1/3 of them had symptoms, 2/3 of them had no symptoms. And these were picked up because of a careful screening and surveillance system. So there's obviously a lot to this story, both from COVID and the vaccine, it sounds like. And I think we will learn more about that over time. I'm sure we will in the student athletes, because it's an important question. If I've had COVID, when is it safe for me to go back and compete? So that's a big question. So we have another question in the audience. Hi.
My name is Mark Moran. Gerald with the police department in the Office of Emergency Management. So the longer the virus is around, the more opportunity there is for it to mutate or have additional variants. The FDA right now is not recommending a booster, but if in the future that does become a recommendation, what would that look like? So would you need an additional dose of the vaccine you already have, and where would you get that, and questions like that? And as a second part to that, would that be something that UMB would then mandate as part of the vaccination requirement?
Sure.
Either of you?
I'll let you have a specific part about the.
Sure. So the question was, we've seen a lot about the need or the potential need for booster doses, and that's been publicized by several of the vaccine manufacturers. And there's ongoing dialogue with the US government officials and the vaccine manufacturers regarding the need for a dose. So if a booster dose is needed, the question is, how will that look? Will that be something that we can give with a different vaccine manufacturer, or will it need to be the same vaccine manufacturer? And my answer to that is we simply don't know. Yeah. We do have studies that are ongoing, these mix and match studies, to determine if a booster dose with a different vaccine manufacturer is acceptable. And one of those studies is being conducted right here at the Center for Vaccine Development. So we're contributing to that effort. And the other question you had was part two, when will we know it, or exactly?
If it would be mandated.
If it would be mandated. I'll pass.
Look over here. The way I would answer that is, how did we make the decision to mandate it the first time around? And it was a public health decision. I also would add that we're on a health sciences campus, and I think it's very important for us to keep in mind the safety of our patients is obviously a very important step. So I think if data were to come along to say that the Delta virus, the Delta variant is really out of control, and that there were data to say that a booster would benefit, then we would look at it from a public health point of view, and that's how the decision would get made. But there's certainly no decision about that at the moment. But those are two big ifs, and obviously neither of them have been proven to be true at this point. The one thing that I think Dr. Lawrence mentioned that I just want to emphasize for the audience is that there is this thing called the Center for Vaccine Development, and there are these things called clinical trials. And it's really important that you and this UMB community participate in those trials. I was in the COVID trial, but I was in 4 other trials before that. I've gotten to know them well and developed a lot of trust with what they do. And I think it's really important that you've got to practice what you preach. So I just want to raise the point of making sure that people understand that you got to support the CVD to get answers to this. In my case, they needed people over 40. I just barely qualified, but I did, and so I agreed to do it. Alex, do you have other questions?
We do. Another pharmacy professor. This is Linda Simone-Wastola, who writes, thanks for the discussion. There are increased reports about breakthrough infection among those who are fully vaxxed coming out of Norway, the UK, the CDC, and many of these are resulting in hospitalization and death. Given that vaccinated individuals are susceptible to infection and can transmit, why is the campus requiring only the unvaccinated to wear masks continuously and practice social distancing?
Going to take a step?
Yes, please.
Sure. So I think that the question is related to vaccinated individuals, and some reports that we have of these individuals who are fully vaccinated might be having what are called breakthrough infections, and that is they're having COVID-19 infections that occur after vaccination and after full vaccination. And it's true that these are occurring, but if you look at the populations in the US that are fully vaccinated and their risk for hospitalization, the individuals who are being hospitalized now for COVID-19 are the unvaccinated population. So those who are fully vaccinated have very, very minimal to no risk of hospitalization. So for that reason, that's why, and Dr. Gerald can confirm, but that's one of the reasons why the university is encouraging vaccination, and that is to decrease an individual's risk of not only acquiring the infection, but also of having the severe consequences of infection, including hospitalization and potentially death.
Yes, please.
Since we were talking about, how am I gonna know what few of my coworkers have been vaccinated and if I do know that they're not vaccinated and I see them not following protocol, what should I do?
That's, go
Yeah,
ahead,
no,
please.
those are great questions, and I think as we're returning to work, what's important again is to have open conversations, and so to ask about, we just introduced ourselves and we weren't sure, like, do we fist bump, do we handshake? We're in this kind of strange, we did the bump, but it's kind of like, it's important as you're coming back into the office to say, hey, do you guys feel okay? I have my mask on, I'm gonna keep it on. I was with grandkids who had some, little bit of cold symptoms, so I'm going to keep it on. So just to be mentioning that and to be talking about it, and I think if you can create that community amongst your colleagues to be really open and say, and so that way people feel safe about saying, actually, I don't feel comfortable, can you please put your mask on? And that's what we're starting to see in different social settings. So just to kind of get a sense of where everybody's at. And, it's, that way people can start to accept, like, well, right now people don't feel comfortable, so we'll all put our masks back on. And I think that's one way to take away removing it from this person's vaccinated, this person's not vaccinated, to kind of create that culture of being able to talk about it openly, and then default to wearing masks when you don't feel comfortable. And I think that's fine.
But we're not gonna have little
Yeah.
stickers that say I am or I'm not or whatever. I think the other important part about it, actually, this is part of coming back to UMB. I don't know about the rest of you, but I care a whole lot about the people who are around me. And I consider it a personal responsibility to make sure that I'm acting in the best way. And I would hope that the people around me would feel the same way. There's no airtight way to do that. There's no airtight vaccination that says I'll never get COVID either. I mean, there's no guarantee like that. But having a community that cares about one another, I think, is a really important step. And I guess I would urge that attitude. We're not allowed to break somebody's privacy. There are rules about that. But we do have I think, an employee right to know when people are not following the rules. But hopefully people will follow the rules. And with the high level of vaccination that we have here, I feel pretty optimistic about it. But that's just me, okay? Yeah, Joanne.
I have another question. This is sort of kind of like a painting the landscape because I think I'm sort of interested in the perspective from you. What is the world going to be like right now and maybe a little bit going forward for those who haven't been vaccinated versus those who have? Like, I'm looking forward to going to like concerts and restaurants and visiting my family in California. And we have this virus, we have the strong variants, we're going to probably have more variants. I was wondering if each of you could just sort of paint what it means, like if you're vaccinated and not vaccinated, this is like what the world will look like for you. Well,
A really important question, because we know that if you're not vaccinated, you are at risk to get COVID-19. Just last month, as Alex had mentioned, there were about 100 people who died in the state of Maryland, and every person who died was not vaccinated. So it's very important that there is that distinction about if you're vaccinated or if you're not vaccinated.
Sure, and what we know about the variants today is that for those who are vaccinated, while you might have a breakthrough infection, you're not going to end up in the hospital, you're not going to end up with the severe consequences of COVID-19. So no matter what variants come along, we hope that that still remains true and that will be the case. But it will be very different as far as risk for severe complications of COVID from the vaccinated individuals and the unvaccinated individuals.
I say this at risk by sitting next to a psychiatrist. But what I would say is human nature is we're going to revert back to the way we were. I can't see anything but that, which means that there will be periods of time when we have outbreaks. And I think Dr. Lawrence perhaps can comment about the polio vaccine in different parts of this world where people have rejected the concept. And then there have been outbreaks of polio. Do I have that right?
Absolutely, that continues, and fortunately, we've made great strides in polio, but it's communities that are resistant to vaccination, that is where we're seeing outbreaks that are occurring, and at least that's part of the problem. So acceptance of vaccines is a huge hurdle that has to be crossed for a community to successfully work against any disease.
Yeah. And I'm sorry to say that I remember the polio days a little bit, and I remember when every pool and everything was closed, then these two vaccines came along, and suddenly it was back to normal very quickly, is what I call it. I was only about that tall, but it was a pretty quick recovery, as I recall. Other questions, Alex?
We do have another question, and really it reflects what a lot of people have been talking about. People have different health needs. They have different reactions to the vaccine, and so they're concerned about these talks as variants and boosters. And this anonymous questioner writes, if someone had a severe reaction to the second dose, extremely high fever, chills, etc., should they be concerned about getting a booster shot?
So the question is there concern about getting a booster shot for someone who had a severe reaction to the second dose? And it depends what that reaction is. Certainly, if that was a very severe, what we call anaphylaxis reaction to the vaccine, then no subsequent doses of vaccine from that manufacturer should be given to that individual. Fortunately, we have a variety of COVID-19 vaccines and more that are coming online, so there will be more opportunities for other vaccines with these mix and match studies in the future. But for now, that person should not be vaccinated with the same product if they experienced anaphylaxis. If it's a mild allergic reaction, then that can be managed and that can be anticipated and again treated if it occurs again, if and when a booster dose might be needed. And just to address the booster dose question again, when will we know that's a big question. When will we know if the booster doses are needed? And that is something that we continue to monitor. Individuals continue to be followed up from the COVID-19 vaccine trials that started last year. We are looking at these individuals very carefully, and it's when those individuals who've completed vaccination begin to have several breakthrough infections, that's when we'll carefully look at if a booster dose and when a booster dose might be needed. That's an important component.
It's a similar question we've seen a lot is about children, that people say, well, you know, my child probably, even if they got the disease, might not, you know, they're hearing that they wouldn't be as severely affected. Do I really want to get them a booster shot or a vaccine at all, given that the reaction might be worse than what they would face getting the disease?
Sure. So the current vaccine trials that are being conducted in children are looking carefully at the side effects. And they're not just relying on parents to call them up and say, oh, this happened to my child, you know, please put that in your records. We are actively following up these children using electronic diaries that are phone-based apps that question and query parents regularly on the days after vaccination. So the safety profile of these vaccines and any side effects that occur are known and are continuing to be collected. So parents will know exactly what to expect and what their child might have after vaccination. And with that information, they're armed and they can make a decision, am I willing to have my child vaccinated? Fortunately, so far, we've seen a very similar side effect profile in the pediatric populations to date. And that is that these side effects can occur with vaccination, but the side effects only last for a couple of days and then they go away.
Laura?
So many people feel that the vaccine was rushed, that they feel like, you know, we didn't give it enough time in clinical trials to really know what the side effects or what the long-term effects maybe of the vaccine will be. Can you talk a little bit about that?
Sure. So the question is, many in the public feel that the vaccines were rushed and that data wasn't collected completely, and we might not have a complete idea of all the safety profile of these vaccines. And the answer is, I see the rationale and the reasons why people might think it's rushed, because vaccine development typically takes years. And this vaccine went into production only months after it was sequenced, as far as the genomic sequence and manufacturing occurred quickly, and then clinical trials occurred soon after that. And the answer is the monies that were supporting this vaccine development effort are what allowed it to advance so quickly in the vaccine development process. The go, no go criteria to advance into larger populations and more people receiving vaccine was based on support from our government and from the vaccine manufacturers to advance all of this. So it wasn't for lack of data. The data continued to be carefully collected and characterized. The required number of individuals had the minimum number of months of data that was collected and presented and evaluated by the FDA and presented by the pharmaceutical manufacturers. So we do have a very complete and robust safety profile. And again, these vaccines were made quickly in response to a pandemic. So the pandemic was the threat. And that's why these had to be advanced and we had to develop them quickly because our goal was to decrease the number of lives lost due to COVID-19. None of these vaccines are licensed, so none have the complete safety profile that the other licensed vaccines on the market have. That's a goal in the future, but again, to receive that emergency use authorization, there was no sidestepping, there was no missing of important data. These vaccines were completely characterized before that emergency use was allowed.
You may not know the answer to this. I know when you talk to the pharmaceutical companies about the development of a new drug, it's 3 to 4 years and about $1 billion. Do you have any idea what it costs to bring a vaccine in the old method and the new methods? Have you ever heard a number on that?
It's definitely in the millions of dollars and definitely usually 10 years in development minimum. For some vaccines, it's much longer. So it really depends on the vaccine and the technology that you're trying to develop. For some targets, for instance, HIV, we still don't have a vaccine, and that's still being developed, and millions of dollars have gone into it. So it really depends on the pathogen and the approach.
Alex, I think we have time for one more question.
We have a few. Here's one woman, someone who wants to remain anonymous. She says, what do you say to someone who has many health issues and everyone is telling her to get the vaccine, yet her gut tells her that she will get very sick and possibly die?
That's a great question. And so it's really important to, when she's talking with her healthcare professional, to let them know that and to ask, allow that healthcare professional that really kind of understand specifically what other concerns she has. So a little bit more about that sense of the fear of dying. What else? What does she think about the vaccine might potentially contribute to that? What does she know people? There's a lot of information to kind of get through to help kind of understand where that's coming from. And, we can give facts and present facts again and again. And, sometimes hearing it in a different way from a different person. I always like to ask, what, if you could at this moment, what would convince you? Is there any piece of information that would change your mind? And sometimes there isn't. And then that's an important dialogue to continue. And so, individuals they know themselves, they know where they're at right now. And it's important just to keep being open to having those dialogues and those conversations.
Alex, maybe one more. Then we're done.
Here's a good comment from someone named DQ, who writes that I wanted to say he, but it could be he, she, could be anything. But DQ writes, I think it's really important that we don't keep invoking the idea of vaccine resistance. It puts the onus on communities. And when those of us who study in health know the issue is not about individuals often, but about structures of care that are not accessible. There are many people who they're sort of wrongly lumped into that resistant category. Really, it's not easy for many people.
Absolutely. We have a lot of barriers in different communities, whether that's transportation, understanding just, how challenging it is to be able to, seek getting outside and having that healthcare, or even feeling that they have this emotional support to be able to do some things that are challenging. And so, that part this is a great point. And so it's important that we continue to send the message, this isn't about judgment. You know, we're not judging people by saying that somebody is not the resistance part, because I think it is lumped in with a very negative connotation. You know, we're in a pandemic and we want people to be well. We need our world to embrace. We have to have public health measures at the same time that we can respect everybody's viewpoints. And, you know, so me, I think we do sometimes have to change the language and the way in which we interact with different individuals. So.
Dr. Lawrence, anything to answer?
I completely, yeah, thank you. I definitely agree. And the vaccine resistance is sort of a misnomer. And basically, we need to find out what are the barriers to access to vaccines and other barriers that communities experience, so that way we can break down those barriers and make healthcare and vaccines available to all, whether it's after hours care, whether it's providing childcare for others while they can go and get vaccines or go for medical healthcare visits. All these need to be addressed, and COVID-19 has certainly highlighted this in some communities. But the unfortunate fact is that many of the counties and zip codes where socioeconomic status and other indicators are very low, those are also the communities where vaccination rates are very low. It's up to us to change that, and I agree that we should continue this dialogue.
So I think that puts us out of time. First of all, thank the two of you very, very much. Most stimulating discussion, and it was so wonderful to have a discussion, okay, and back and forth. I got a lot out of that, so thank you for that. For our audience who's here remotely, thank you for participating, and for those of you who actually showed up here, way to go. Thanks a lot. It's nice to have you, and next time, more of you. See more of you, okay? So with that, I will sign off, and Alex, turn it back to you.
All right, well, thank you, everyone. We have information up here in the boards, which you may not be able to see at home. Reminding everyone to make an appointment. You can still visit getthevaccinebaltimore.org. Learn more about COVID-19 protocol on campus, visit umaryland.edu/coronavirus. Oh, there the camera's moving. So with that said, good afternoon.
Thank you.
Thanks.
Thanks.